Okay, this is your last PowerPoint before the test of new information. So this is the last thing you're going to have to learn before the test, but then we're not going to have the test until I believe it was next Wednesday because we don't have class on the Monday. So we will just be doing review for Wednesday and Friday. We will play Exam 1 Jeopardy on either Wednesday or Friday, we'll see. And that will get you your last final extra credit points before you have the exam on Wednesday. Okay, and that is, the exam is online. On that day that you have the exam, you don't come to class that day. So you just go take the exam. Okay, so this is review from last time. So we already did these basically, but going over the muscles, we're doing the hip flexors. The red ones are the ones that we're learning. So those ones are review. So iliopsoas is going to be our first muscle. So generally, muscles on the anterior side of your hip are going to be hip flexors. So these are going to be kind of our hip flexor groups. The iliopsoas is a muscle that is actually made up of two muscles. So it is made up of the iliacus, which we can see right here, and the psoas major, which we can see right here. So the origin of the iliacus will be the inner surface of the ilium. So the inner surface of the ilium is the inside aspect of the wing kind of shape. So of our nominate bones, if you remember, our ilium was the top region. The inner surface is just literally the inside of it. So this smooth part is where the iliacus will attach onto. So this whole smooth part. The psoas major and minor are actually going to be coming off of your spine. So they are coming off of your vertebra T12, which is your thoracic vertebra 12, which is your last thoracic vertebra, and your L1 through L5, which are your lumbar vertebrae. So it will be coming off of, you can see here, L5, 4, 3, 2, 1, T12. So this psoas will be coming all the way up off of these vertebrae. It's also going to come off the base of the sacrum, which is actually the top of the sacrum. So basically it's coming from all up here, which is probably much higher than you thought your hip flexor goes, right? So insertion, the iliacus and the psoas portion of it is going to go to that lesser trochanter. So that lesser trochanter was on the medial side of that femur. So it will be coming down, wrapping in, and inserting on that lesser trochanter right in the medial aspect. The psoas minor, which isn't even really pictured on here, it's going to kind of delve off and go to the pubis, which we know is right here. So its action, it is going to do hip flexion. It's on the anterior surface. So it's going to be bending that hip. It's going to do that anterior pelvic rotation that I talked about last time, which remember was the rocking of the hips forward, the ASIS moving anteriorly. And it's going to do external rotation. So it can do it with a straight knee like this, or with a bent knee like that. External rotation. So this is the muscle. Has anyone ever gotten their psoas released before? No. It's very unenjoyable. So if you do get it done, be prepared for it to be very uncomfortable. But if it's really tight, sometimes athletic trainers or physical therapists will do muscle releases. And for this one, you pretty much go all the way up here. You have them breathe in as much as they can and exhale out, and you just push all the way down until you find their psoas, and then you have them move through hip flexion and extension while in that position. So it's very uncomfortable, but it works pretty good if you have a very, very tight iliopsoas. But it's dangerous. Don't do it because you have to get around internal organs. So, next hip flexor muscle is going to be our pectineus. This is probably a muscle you have never heard of. And sometimes, if it's my in-person classes and we had so much material, I would just tell them to forget about this one. But we'll learn it. So pectineus, oops. So this is kind of going to be in a group. We'll see it when it's more built up. We have a ton of other muscles here, but this is with it all on its own. So its origin is going to be that pubis. So pubis right here. Its insertion is going to be the linea aspera, which if we remember was the line coming down the posterior surface of the femur. So you can see it's going from anterior and coming posterior. So it's following this path, going behind your leg. It is going to do hip flexion, adduction, external rotation. So hip flexion, we know bend, adduction, bringing it in, still that external rotation, and that anterior pelvic rotation again, so rocking forward. Okay, you should already know rectus femoris, right? Because this was in the knee muscles, but it's on here again. Because your rectus femoris is a hip flexor, right? Across the knee and across the hip. So you already know this, but I put them on there again for you. Same with sartorius. You already know sartorius, but you know it does hip flexion, that figure 4 position, but it's on there again for you. Okay. So we're on to the posterior muscles, which we know we only have 2 new ones we have to learn, and we have all of the hamstring muscles. So you've probably heard of your glutes, right? Pretty common, especially if you work out, you know about your glutes. Your glutes are actually made up of 3 muscles. You have your gluteus maximus, your gluteus medius, and your gluteus minimus. But your gluteus maximus is going to be mostly on the posterior side. It is like the biggest glute muscle, hence maximus. It's the biggest inside. This is what you're going to classically think of as your glutes, as your butt muscle. So the origin of the gluteus maximus is going to be posterior. It is the posterior 1/4 of the crest of the ilium. Basically, what that means in fancy words is we know this is our iliac crest, right? The top region. The posterior 1/4, so we're going to be on the back side. 1/4, we can say, okay, that's about half, so about here. So it's coming from the last bit of that iliac crest. It's then going to go along the entire side of the sacrum. So it will be following that whole sacrum all the way down, following it all the way down to our coccyx. So it's running along this entire edge, all the way down to the tip. So you can see right here, going from the posterior iliac crest, following the whole sacrum, all the way down to the coccyx. So it's actually a lot bigger than people think. The insertion site is going to be lateral surface of the greater trochanter, which just basically means the complete outside edge of that greater trochanter. And it's going to attach to the IT band. So we can't see the IT band on there, but we talked about the IT band, right? And it's just a bunch of fibrous tissue, not a muscle. It's going to attach onto there, which is why people think the IT band can move because you got muscles attached to it. The glute max is your main hip extensor, so it brings your leg back. And it also is going to do external rotation. So your glute max is going to be that main muscle. It's like if you were walking up the stairs and you went to push off, that's going to be your glute max. So you often see people doing like donkey kicks and like kick leg backs to try to grow their glutes because they're just doing hip extension. Okay. We already know biceps femoris. It's our lateral hamstring muscle. We already know semitendinosus. It's the medial hamstring muscle sitting on top of our semimembranosus, which we already know. Okay, so then our next posterior muscle is what's called the 6 deep external rotators. So it's actually made up of 6 muscles: your piriformis, your gemellus superior, gemellus inferior, obturator externus, obturator internus, quadratus femoris. You don't need to have all of these memorized. I would say the most important one that you guys should know is piriformis is the most important. So you do need to know that, of course, the 6 deep external rotators are made up of 6 muscles, but mostly just know piriformis. I'm not going to ask you these other ones because I don't even know them really. I don't use them, except for piriformis. So the origin is going to be quite a few different spots because there are 6 different muscles. So we're going to have anterior sacrum as one, posterior ischium as one, and obturator foramen. So anterior sacrum, we're going to have some muscles, even though they're on the back, they're going to kind of slide through this front and attach onto the anterior surface of the sacrum. So we'll have some that go through this little hole, this notch, attach onto anterior sacrum. We'll have posterior ischium, which we know is the lower region. So they're coming off this lower region of the pelvis. And your obturator foramen. Foramen means hole. So if you can see if I can pull this up. It's going to come out. Can you see these holes? Okay. So these are your obturator foramen. So these holes in the front. So you can see right here, these 2 holes, which coincidentally have the 2 muscles that say obturator in their name. But the most important one is that piriformis. So you can see that piriformis is coming off of the anterior sacrum. And then they're all going to insert onto the greater trochanter, the superior and posterior region of the greater trochanter, basically meaning the top of this greater trochanter and all the way down the back. Hence their name, their action is external rotation. The piriformis is so important because your main nerve that supplies your whole lower leg, your sciatic nerve, runs directly underneath the piriformis. Now, if you've ever had sciatica, which is basically like inflammation, pain of that nerve, most of the time it's caused by too tight of a piriformis. Your piriformis will get tight and contract, and your sciatic nerve is super thick, really big, like a rope, probably like this big around, and your piriformis will squish it, giving you all those sciatic nerve symptoms. So a lot of times people don't understand that when they're having those nerve symptoms all the way down their leg into their foot, it's actually oftentimes due to a very tight piriformis. And there's another muscle release for this one that is also extremely uncomfortable. Okay, so lateral muscles. These are the ones we haven't learned any of them yet. So we know that lateral muscles are going to be hip abductors. So anterior will be hip flexors, posterior will be hip extensors, lateral are going to be hip abductors. So we've got our next in our glute group. We have our gluteus medius, which hence its name. It's kind of the medium-sized glute. So these are all going to be deep underneath the gluteus maximus. So our gluteus maximus will be the most superficial of all these glute muscles, and then we're going to start going down. So our gluteus medius is going to be in the middle between the other two. It's about medium-sized. So its origin is lateral ilium, just below the iliac crest. So we can see on this picture, we have that iliac crest right here, and it's sitting just below it. So on here, you can kind of see where the iliac crest ends. It's going to go just below that iliac crest. It's going to insert onto that greater trochanter, but the posterior and kind of middle surfaces of it. So you can see it's coming right onto the greater trochanter right here. And the gluteus medius is going to do abduction. So that's why a lot of times if you want to work your glutes, you shouldn't just be doing hip extension. You should also be doing abduction. This muscle you're also going to feel if you've ever kind of tried to stand and balance on one leg and you're trying to keep your hips in line. You'll feel that contracting. Sometimes if people have really weak gluteus mediuses, they'll have what's called Trendelenburg, which is a very fancy word. Basically that means, so if I'm standing like this, you can see my hips are nice and even. If I totally pop out my gluteus medius, then my hip kind of sinks in. So I contract my gluteus medius and then not contract it. So sometimes if people have really weak ones, you'll see people kind of like walking like that, or when they try to stand, they can't control it and they'll pop it out. So it's kind of fun. You can watch people when they walk and figure out what's wrong with them. Okay, next glute muscle, gluteus minimus. It's the smallest, mini. So its origin is super easy, especially if you're just on like my tests. A lot of times you just need to be able to recognize. So you know that this is beneath the gluteus medius, and its origin literally has gluteus medius in its name. So it is going to be on the lateral ilium as well, but just below the origin of the gluteus medius. So the gluteus medius, we know it's going to attach right here, all along. So the gluteus minimus is going just below that. So we'd have it kind of be just in kind of the midpoint of this lateral ilium. It is going to insert onto the anterior surface of the greater trochanter. So kind of tilting more towards the front. And it's a lateral muscle. It's going to do abduction as well. Okay. Next muscle is one of my favorites because of its name. So you can say tensor fascia lata. You can say latte, but I say lata. So tensor fascia lata, which can be abbreviated as TFL. This muscle, which is right here, is going to be at the very top of our IT band. So its origin is going to be anterior iliac crest. It's almost at the ASIS, which is this point, but it's not. So it's just the very anterior region of that iliac crest. It's going to insert basically a fourth of the way down on your iliotibial tract, which is your IT band. So we can see it comes down and inserts onto that IT band. So that's why contraction of this pulls on that IT band. And then the IT band goes all the way down to Gerdy's tubercle. So that's why it says to Gerdy's tubercle. So the TFL goes to the IT band, then the IT band goes to the Gerdy's tubercle. It is going to do abduction because it's on the lateral side, but it's almost completely anterior as well. So it's going to do hip flexion. So it kind of assists with hip flexion. So you can see here as well, see that glute max attaching onto that IT band right here. So all of this white is that IT band, or it's often called the iliotibial tract. Okay. Now we're finally getting to medial, our last kind of group, which is going to be hip adductors. So bringing them in. So we're going to have a group of 3 muscles called our adductors. We're going to have our adductor longus, our adductor brevis, and our adductor magnus. So we can see we have our longus right here, our brevis right here, and our magnus right here. Again, the last portion of their name, so adductor is what they do. Longus, brevis, magnus is describing their shape or their size. So the adductor longus is going to be longer than the other two. Adductor brevis, you can think like brief, it is shorter than the others. And adductor magnus, you can think like magnum, it's like the biggest. So it is going the widest area. So starting with adductor longus, which is this front one, it's going to be coming from anterior pubis, so front of the pubis bone. It's going to insert, as they all are, onto the linea aspera, but they go into different portions. So the adductor longus is going to go to the middle 1/3 of that linea aspera, and it's going to do adduction, as we know, or adduction. Versus the adductor brevis, we can see right here, is going to still, basically it's going to come off of the pubic bone again, but just below the adductor longus. So that inferior pubic ramus, just know the pubic bone again, pubis, just below the adductor longus. It's going to insert onto the pectineal line of the femur, which is just another line on the back. But the key part is the upper 1/2 of the linea aspera. So this, even though it originates just below the longest, it's going to insert above the longus. So it would be, we could say longus is probably going to go right here versus brevis will be all the way up here. So it's inserting above it. It's going to do adduction and external rotation. Oftentimes how I remember this, I make weird connections between words or try to come up with clues. So because adductor longus does not do external rotation, I think of, because brevis has the RE, it does external rotation. That's how I often remember it. You got that RE here, so then you can remember it's the only one that does external rotation. And lastly, that adductor magnus. So it's going to originate, basically it's going to come off the entire pubis, but it's also going to come off of the ischium and the ischial tuberosity. So it's basically going to be hitting this whole end region, so that whole kind of curve. It's going to insert on the entire linea aspera, so it's covering it all up. What's called the intercondyloid ridge, don't really need to know that, and the adductor tubercle, which if we remember, the adductor tubercle was this bump on top of the medial femoral condyle. So the bump on the inside. And it's just going to do adduction. Only the brevis has external rotation, hence the RE in its name. Okay, gracilis, you already know. You already learned it, so it's another adductor. Any questions on the muscles of the hip? Okay. So some other soft tissue there, we're going to have our labrum, and we're going to have some ligaments. So because the hip is a ball and socket, it's going to have a labrum, just like the shoulder does. And basically the labrum is going to be kind of like a suction cup holding that femoral head into the acetabulum of the innominate bone. So kind of enveloping this, kind of keeping it nice and tight. And it's going to be, again, soft tissue material, so it can rip easily. Well, not super easy, but we're also going to have ligaments. So you can see we have 3 ligaments. We have an iliofemoral, pubofemoral, ischiofemoral, which are getting their names based off of the different regions of the pelvis, right? So they fully envelop and wrap around that femoral head, so giving it a lot of stability. So that's why our hip is so stable, because you saw how many muscles are around it. Then we have a labrum, then we have these thick ligaments going all around it. So injuries, though, can still occur. Probably the most common we're going to have is a strain, which we know is an injury to a muscle. So hip flexor strains are probably the most common you're going to see out of any of them. We see them a lot in athletics. We can have sprains, which would be the injury to the ligaments. These would be much harder to get in a hip. It would be a much more significant injury or mechanism. We can have labral tears, so tears to that kind of suction cup lining, often from repetitive pivoting, so planting and pivoting, and a lot of stress on the back of your hip, so you can get these from squatting as well. Of course, dislocation and impingements. So dislocation is obviously going to be the most life-threatening. And we have a couple different dislocations. So we'll have posterior hip dislocations and anterior hip dislocations. So we can have our head of our femur come out of the acetabulum posteriorly, so through the back, or we can have it anteriorly. How you can recognize hip dislocations: one, they'd be in a lot of pain, and you would look at the position of their leg. So when people have a hip dislocation, it moves their leg in a really weird way. So oftentimes, I think it's more common to see posterior hip dislocations. Especially if you work in EMS or anything, you may come on car accidents where the person will have their leg kind of turned and it will be shorter, significantly shorter, because that femur has now slipped out up here, so it's shifted that whole leg up. So you'll see someone kind of with like a sucked up leg, and they can't move it, so it's pretty obvious it's a hip dislocation. They're obviously more rare. Oftentimes, you will see posterior hip dislocations in car accidents. So if you work in a physical therapy setting, you might see this more than in an athletic setting. Because can anyone guess why you'd get a posterior hip dislocation in a car accident? Has anyone been in a car accident really bad? So if you're hit, and maybe if you're tall, your knee will hit the dashboard, shooting your femur back through your leg. If it's very significant, it can actually tear through your glute muscles, so it can completely tear your glute muscles. You also have an artery running through the tip of the head of your femur into your acetabulum, and you can tear that. So if you're a sports fan, have you heard of Bo Jackson? So he suffered a posterior hip dislocation, I believe, while playing. He tore through his glute muscles and he ruptured that artery. And I don't think they realized he ruptured that artery. And if there's no longer that artery, your bone dies. So you have no blood supply. So I believe in him. I could be totally messing up his story, but I'm pretty sure this is what it is. His was ruptured and he got avascular necrosis. So basically death of a bone because you have no blood supply. And he had to get a hip replacement because the bone died. So obviously hip dislocations are super life-threatening, and you got to make sure you do EMS. This is a type of dislocation that an athletic trainer or even a physical therapist, you would not attempt to reduce this. You would not try to get it to go back in place. This would be an EMS call immediately because you don't know what has been broken in here, and you don't want to be yanking on something and shoving shards of bone into nerves or arteries. Next is impingements. So impingements are oftentimes happening in people who kind of seem like they have chronically tight hips. Even when their muscles aren't really tight, they might have just really bad mobility in their hips. And you may have an impingement. So there are two types of impingement: a cam impingement and a pincer impingement. Basically, a cam impingement is going to be you have a big overgrowth of bone on your femoral neck or your femoral head. So if you try to move and you got that bony growth, it's going to block you because you can't fit in there. Versus a pincer impingement is an overgrowth of your acetabulum. So this top part kind of goes over and around. So then again, if I have bone coming over around here, and I try to move my hip, it's going to get blocked by that bone. So impingements. Okay, so that is it. Make sure you are prepared and study. Maybe make yourself a study guide or a reference sheet for Jeopardy. Because as we saw last time, if nobody knows anything, it's really boring Jeopardy. So let's make sure we are prepared for Exam 1 Jeopardy next time.